Thank you, Jean-Michel. It's a pleasure for me to present to you the methods and results from Cape Town of the HPTN 067 ADAPT trial. I'm speaking really on behalf of Linda Gale Becker, who first presented this information at the CROI meeting earlier in the spring. The study was sponsored by the National Institutes of Health. As background, oral FTC-TDF PrEP is effective for preventing HIV acquisition. Protection after rectal exposure is estimated to be near 100% with use of 4 or more tablets per week, and 84% with use of 2 to 3 tablets per week. However, full protection after vaginal exposure appears to require more PrEP use than these levels. Sex is often planned, and plans change over time. This is clearly demonstrated by pioneering work done by Fritz von Greenspan, who is a co-protocol chair for this study, and in some ways our inspiration for it. PrEP provides benefit when used during seasons of risk, and such strategic PrEP use has been observed in men who have sex with men, but not as frequently among women. Measurement of adherence is challenging, especially when adherence is dynamic. Recommending PrEP dosing before and after sex leads to effective use among MSM, taking on average 16 tablets per week. Thank you very much to Jean-Michel and his team for showing us that. Adapting PrEP regimens to match patterns of sex could increase strategic PrEP use and minimize medication costs and side effects. This hypothesis was addressed in the HPTN 067 trial design. The study enrolled women, and including transgender women and men who have sex with men, into a 34-week study, including 6 weeks of directly observed therapy with open-label oral Truvada. And then after 6 weeks, there was a randomization to one of 3 dosing regimens. The daily dosing arm was a recommendation to take 1 tablet per day. The time-driven arm involved 1 tablet 2 times a week with a post-sex booster dose of a single tablet. And the event-driven arm involved 1 tablet pre-sex and 1 tablet after sex. All participants were advised not to use more than 2 tablets in a day or 7 tablets in a week. After randomization, individuals were followed for 24 weeks of self-administered dosing for evidence of coverage of sex acts with pre- and post-exposure dosing. That was our primary outcome. Adherence and PrEP use was measured electronically using the Wise Pill device, which sends a message to our server every time the device is opened. We also did weekly telephone calls to check in about sexual intercourse episodes, including date and time. After the 24-week self-administered field dosing period, there was a period for qualitative research involving key informant interviews and focus groups. These information will be presented in this special session by the series of speakers to my right. The HPTN 067 study was conducted at 3 sites around the world. Women were enrolled in Cape Town, and men who have sex with men and transgender women were enrolled at Harlem and Bangkok. Each of these 3 studies was independently powered for separate analysis based on the premise that the socio-cultural context would determine the feasibility and acceptability of the different dosing regimens. The primary outcomes of the study were coverage of sex events with pre- and post-exposure dosing, the number of tablets required and the number of tablets actually taken, self-reported side effects. Secondary outcomes included adherence to the particular regimen, safety, acceptability, and HIV infections. These studies were not powered to assess efficacy. The primary outcome was coverage of a sex event. This was defined as having taken 1 pill or more in the 4 days prior to sex and 1 pill or more in the 24 hours after sex. This same criteria was applied to all 3 dosing recommendations, all 3 arms, and with 100% adherence to the recommended dosing, coverage would also have been 100%. So let's review the results from Cape Town. 294 women were screened, and 191 were enrolled, and 179 were randomized to one of the 3 dosing regimens on a 1-to-1-to-1 ratio. Importantly, 6.8% of those who failed to be enrolled were already HIV infected in an unexpected way, and 2 became infected during the DOT phase, highlighting the very high risk for HIV in this cohort. At baseline, the cohort in Cape Town had the following characteristics. They were all women. They were mostly young, having a median age of 26. 80% were never married. 83% were unemployed. 99% were black. And all were residing in or near the crossroads area of Cape Town. So the primary outcome was coverage of sexual intercourse with pre- and post-exposure dosing. You can see in this slide that 75% of women randomized to the daily arm had, 75% of the sex acts in the daily arm were covered with pre- and post-exposure dosing. Complete coverage was lower at 56 and 52% among women randomized to receive recommendations for time-driven or event-driven dosing. On the right, we see that sex events that had no coverage with either pre- or exposure dosing were relatively rare, occurring in only 6 to 7% of sex acts. Of the partially covered sex acts, the majority of women were missing the post-exposure dose, highlighting how the post-exposure dose was the more challenging dose to take. In terms of number of tablets required and taken by arm, again we see the daily dosing arm required the highest number of tablets for full adherence, and the number actually taken was also the highest compared to the other arms. Adherence was highest in women receiving a recommendation for daily dosing of PrEP, and adherence was on average 81% in that group. It was lower in the time-driven arm and still lower in the event-driven arm. HIV incidence was observed in all 3 dosing arms. There were 2 seroconversions during the 6-week pre-randomization, which involved daily observed therapy, but daily observed therapy of only 1 tablet per week. And we did this phase to calibrate our pharmacologic measures of adherence for each individual participant. This represented an incidence density of 8.9 per 100 person years. And in addition, there were 5 seroconversions in the 24-week self-administered PrEP phase, 2 in the time-driven arm, 2 in the event-driven arm, and 1 in the daily arm, representing an incidence density of 5.4 per 100 person years. All of these seroconverters had no or negligible levels of drug at the time of seroconversion. Neurologic and GI side effects have been reported in the context of Truvada use, both for treatment and PrEP, and we see that, such symptoms were reported in 10 to 50% of our study participants. At this particular site, there was a trend toward more frequent reporting of side effects in the daily arm compared to the time and event-driven arms. As reported before, the majority of these symptoms occurred in the first 4 weeks of self-administered use. This is the slide for neurologic side effects. And at week 10, which is the first 4 weeks of self-administered use, there was a slight excess in the daily arm, but that quickly thereafter the arms had comparable levels. These level of side effects are higher than we've observed in randomized clinical trials, and we think this is because we actively assess side effects using a structured questionnaire rather than in the open-ended way that is normally done in trials. Also, with GI side effects, the majority of side effects were reported in the first 4 weeks. In both neurologic and GI side effects, the side effects were mild, self-limited, and did not require discontinuation of PrEP. So drug levels were measured in peripheral blood mononuclear cells, and for this analysis we set a cutoff of 9.1 femtomoles per million, which roughly corresponds to the use of 2 tablets per week, which would have been completed in weeks where sex occurred if they were adherent to any of the 3 regimens. This is a minimal level of adherence to comply with the protocol. And you can see here that 81% of the women at week 10 and 66% of the women at week 30 had this level of drug in the blood. These levels of drug detection are comparable to what was observed in the Partners PrEP study, which showed high levels of effectiveness on an intention-to-treat basis. Rates of drug detection are lower in the time-driven and event-driven arms. So HPTN-067 has several limitations, and the main ones are that thresholds for adherence and drug concentrations required for full protection after vaginal exposure are not yet known. We're looking forward to pharmacological analyses of this issue. However, recent PK/PD modeling suggests that full protection from vaginal exposure to HIV probably requires daily or near-daily use. The ADAPT trial participants, in addition, were informed that daily oral PrEP was effective, but the non-daily dosing was unproven. We've learned from our qualitative research in Thailand that belief in efficacy is a strong facilitator of adherence, such that this message that we were required to send could have undermined adherence in the non-daily arms. Weekly telephone contact, in addition, in this study, could have served as reminders for promoting adherence. In conclusion, the majority of young, predominantly single South African women took oral PrEP when made available in an open-label study. Recommending daily dosing resulted in higher coverage of sex offense, higher drug concentrations, and higher adherence. Daily dosing fosters habit formation, provides the most forgiveness for occasional missed doses, and does not require planning for sex. These findings and PK findings from vaginal tissues support current recommendations for daily use of oral FTC-TDF PrEP in women. Thank you very much.